Hello, friends and colleagues. I am Dr. Ryoon-Ki, an orthodontist practicing in Seoul, Korea. I'm pleased to share my case with you in this October. To correct gummy smile in both anterior and posterior areas, we can consider two treatment options. One is traditional orthodontic treatment combined with fourth one surgery, and the other one is orthodontic impaction of the entire maxillary dentition using temporary skeletal anchorage devices. I present to you a gummy smile case treated by the second option. The female patient had previously received orthodontic treatment with first premolars extracted to correct an open bite. However, she was still concerned about gummy smile and protruded lips and wanted to be treated again. Here are facial and intraoral photos taken before the retreatment. In her smile, you can see the excessive gum display, especially in the posterior area. Amboini multi-slotted lingual brackets and preformed lingual straight arch wires were used to give her a satisfying and aesthetic orthodontic retreatment experience. 2 months into alignment, a mid-palatal absolute anchorage system was designed for posterior superior impaction of the entire maxillary dentition. First, 016 by 022 inch stainless steel preformed lingual straight arch wire was placed in the horizontal slot, and a 018 by 018 inch stainless steel anterior segmental arch wire in the vertical slot. On each side of the upper arch wire, hooks were placed between the lateral incisor and the canine, as well as between the second bicuspid and the first molar. In the posterior mid-palate, ASMS micro-implant was installed, onto which 032 by 032 inch stainless steel power arm was properly formed and placed. The posterior superior impaction forces were applied by suspending power chains from the hook to the power arm for a period of 18 months. Finally, a transpalatal arch was placed to prevent lingual tipping of the maxillary posterior teeth during maxillary impaction. It is difficult to precisely apply the posterior superior intrusive force through the center of resistance for the maxillary dentition. Thus, in this case, the posterior superior intrusive forces were applied to both the anterior and posterior regions with respect to the center of resistance of the entire maxillary dentition. After 18 months of maxillary total impaction, maxillary and mandibular arches were bodily distalized for 12 months in order to actively improve lip protrusion. Here's the mechanism of how the upper arch was distalized. A new 032 by 032 inch TMA power arm was placed into the head of the SMS micro-implant, and distalizing forces were applied by suspending power chains from the hooks to the power arm. At this time, lingual root torque force was applied to the maxillary incisors by suspending power chains from the lever arm to Kobayashi hook tied to the SMS micro implant. Now, let's look at the setup for the mandibular total distalization. Conventional micro implants were inserted on the buccal alveolar bone, and lever arms were bonded on the mandibular canines. Similarly, distalizing forces were delivered by power chains. For bodily movements of both arches during total distalization, we used the lateral set to determine the following: the positioning of the hooks and the form of the power arm in the maxilla, and the position of the conventional microimplant and the length of the lever arms in the mandible. You can see the distalizing forces applied are both parallel to the occlusal plane and through the centers of resistance. Here is the outcome of the treatment. The patient's gummy smile and lip protrusion were improved, and she had a harmonious occlusion. You can see profile change and improved gummy smile. On the superimpositions of SEP tracings, you can see the posterior-superior impaction of the maxillary arch and bodily total distalization of both arches. The 12-month retention SEP tracing shows good stability without obvious relapse. The center of resistance of the unit to be moved is the basic point for the arrangement of a force system. In this case report, centers of resistance and vector forces were arranged on lateral set. The maxillary arch was moved posterior superiorly and bodily distalized using a combination of carefully designed lingual appliances, power arms, and one mid-palatal microimplant. The mandibular arch was bodily distalized with the use of lingual appliances, two lever arms, and two conventional microimplants. Thank you for watching.